Hi guys, this is Dr. Lanier, entrepreneur dentist. I'm sitting here with Dr. Anoop Nandanoor, and he's come on board. He's also alumni of Meharry, and we go way back in that I've been mentoring he and a classmate for a few years, and have some other Meharrians on. So it's not a Meharry only kind of destination, but I'm glad to mentor and also to have a doctor with this kind of skill set. So the reason I'm talking about it today is so that you can understand this is a $5 million idea and above, and I'm willing to invest in this doctor because of who he is and what he's bringing to the table. And I want other doctors to see how a person could be willing to take a chance on you. The reason I am on Dr. Nandanoor is that I've heard a lot about him from his classmates, and then just reading his resume and knowing where he comes from and his background, I said, I'm willing to take that chance. And adult dentistry is something I haven't done in a long time. My sister's an adult dentist, but I wanted to bring someone in that could do it and do implants and so forth. So I chose this young man, and he has a lot of experience. Tell us, now you were practicing in India before coming to the US, and then you went to Rutgers before coming to Meharry, and then you worked. Tell us a little bit about yourself and your background, Doc.
So Dr. Lanier, I'm from India, and I practiced for 3 years after graduation in India. So practicing in India is slightly different from practicing from here. So I came here, I did oral biology, Master of Science in Dentistry, where I did research for 3 years, published 5 papers. And then I did a fellowship in periodontics and restorative dentistry, where I learned implants, the way we cut the crowns, the way we rehabilitate the entire mouth, and so on and so forth. Like I can do the surgery, I can do the graftings, I learned how to place the implants and make sure that they are stable and be there forever. That's my goal. My goal is to give the patients the best look that they want to in the best possible way, and to rehabilitate them and make them eat food in whatever way they want to. So previously, back in the day, the dentures are not like as close to the natural teeth as they were, but with the implants coming into the picture, we are getting close to the natural chewing capability. So as we evolve, the implants are evolving, the implant dentistry is evolving. I want to catch up with the present situation and make sure that the patients get the best service.
And that's it, the state of the art and the best service. And that's part of what I wanted. And by hearing from other Meharrians about how passionate you've been in leading the class and your experience and so forth, and then coming out and all of the courses that you've taken since you graduated, and working already in another practice, and now coming on board, I decided, ladies and gentlemen, to invest heavily. We went out, bought a CBCT, we got the iTero scanner, and anything that he's asking for, I'm supplying, because I know that we are building a team to provide the best of service. And that's the only thing I ask of you, Doc, is to be that person that provides the best of service. As far as selling cases, I'm hiring a really strong treatment coordinator with many years in this field. We're hiring the staff that you need, and we're doing the marketing that will bring all of the patients in, and they're already coming in. So I really appreciate what you're doing, and we had a conversation earlier about the team and building the team and holding them accountable and going through. And I like what you were saying about training your team. And he was even telling me about bringing in and training the team on a mannequin. And I'm thinking, Doc, I don't have a mannequin. Where the hell am I going to get a mannequin? And then you were telling me you have a mannequin.
Yes, Doc. So
go ahead.
So Rutgers taught me some advanced training, but Meharry taught me how to live in the world of dentistry. All right. Meharry taught me the basics of how to stabilize a case, of how to how to actually treat the patient in the best possible way. So I did see the two different sides of the world, but I can say Mehari is like my mother, and Rutgers is like my uncle who has advanced training.
That and by having those kinds of things, and I know you from Mehari, and Mehari, we have a certain thing. I know what you're accountable for and how you're trained, and that allowed me, knowing some other things and recommendations from other people, to set some expectations. And therefore, because I'm an investor, I've already done this thing many times over with pediatrics, and I had some ideas, especially since I had the real estate and the build out and everything to do an adult practice, and I wanted to do two, Visalia and Delano, and I think we can pull from all of the surrounding areas. But I want to build upon what you bring to the table and what I bring to the table and you're the clinician now. I'm also a clinician, but I'm not really practicing. I know quite a bit about dentistry from my many years of dentistry, but I don't know a lot about cosmetic, adult dentistry, implants and things like that, and especially all the technology. Talk about the technology now, Doc, and what some of the things that you're seeing as far as technology.
First of all, thanks to you, Dr. Lanier, for not saying no to anything that I ask. So we recently bought a scanner that can scan everything like an impression, and that can do the Invisalign service, and that can detect the interproximal caries, which we might not be able to detect using the X-rays too. So that's a great tool that we have, and that's the best tool in the market right now. And we need not bother about gagging of the patients. We need not bother about sending the scans, sending the impressions to the labs, which might take weeks and weeks. This will go off the cloud in like seconds, and the lab will receive the order in like 5 minutes, and the crown can be ready in like 2 weeks. So, and other great addition to our clinic is a CBCT. CBCT is the best. I mean, it gives us the 1:1 magnification, which will actually allow me to read the bone accurately for the implants, for the endodontics, and while doing certain other procedures to locate the vital structures, which will help me excel in my clinician way. And thanks to you for providing me all those things that I asked for.
Well, I know if you're going to do it and do it right, I know you need the right kind of equipment. And the state-of-the-art equipment is going to allow you to provide the best of service. And the one thing that I want is from you is just commit to top quality service. We'll find the right patients to pay for it. It's something that we are actually, it's a fee for service. Most of these things, unfortunately, insurance doesn't cover a lot of these things. And we have structured payment plans and so forth. But in order to do it right and have a high quality of service, I wanted to make sure that we got you what you need. So, like you said, the iTero scanner, and that's I saw it, and my son, orthodontist friend of mine, he uses that. He does the Invisalign, and just having that and seeing how it works, and then the scanning for when you're doing preps and so forth. And sending it straight to the lab. I mean, amazing technology that we're using. And then I've never really seen how the CBCT works, but I can imagine if you're doing implants or root canals, to be able to magnify and see the very minute things. I forget this professor at Mehari when I was there, he was saying a great dentist pays close attention to detail. And that is very true. Dentistry, and the reason that dentistry is such a high stress profession is because of the detail. And some people try to scan over the details and just keep moving. But if you're going to be really good clinician, detail. So I like that you were bringing that up and some of the things as far as training your staff and so forth. Speak a little bit about what you're saying, because we have staff. Until this time, we've been doing pediatric dentistry, and we were trying to provide some staff for him until we could hire the adult dental staff. But it's kind of different, pediatrics and doing adult dentistry, and some of the problems that you're seeing, because he mentioned this morning about someone that was cone cutting all of the PAs or foreshortening or something like that, wasn't showing the periapical, and I was telling Doc to have those conversations and let them know what's acceptable and what's not acceptable, and but some of the other things that are concerned when it comes down to staff. Let's just talk about that for a minute. What are some of the things that concerns you that I need to do to make sure you have that perfect staff so that you are one, effective, and that you're also efficient? Because that's the two things, as an owner, I want you to be effective, but I want you to be efficient.
Sure, Doc. So first of all, anything is teamwork these days. I cannot do everything that my assistant does or my EF does or my hygienist does. The hygienist can actually clean the teeth like no one else in the world. And I have my boundaries. I know my boundaries. I want the other team members to know their boundaries as well. That's the first step to success for me. And then going on from there, if we can do whatever we can do in an expedited fashion, but in a very, very detailed fashion, it will make the patient happy, it will make the doctor happy, it will make the entire team happy. That's what I expect from the staff now.
Okay. Anything you want to say about implants themselves? I know there's single tooth, there's different things. So, because I'm not the guy from the street. I'm a dentist, but I still don't know too much about. I have a single tooth implant, and that's pretty much all I know. I know you do the implants, you put a healing cap on, you come back, so forth. But tell me a little bit more about and the different kinds of implants and so forth.
So implants can be used for doing single tooths, we call sometimes it as an overdenture. So we snap the denture on top of the implants. That is called as an overdenture. Or we could do something called overdenture is something removable, but there is something called as fixed. Fixed can be a hybrid, can be a porcelain. So right now we are calling it as all on X. Until we treatment plan, we don't know. We might go with 6, we might go with 4 implants, we might sometimes go more, because the forces that are acting in the mouth is slightly different. And we need to educate depending upon the bone shape, depending upon the ridge shape, and depending upon how much of the ridge is available, the bone is available. If we don't have enough bone that is available, we can do some sinus lift graftings and everything to make sure that we get the room and we get enough bone to play with. So these are the different things that we could do, and there are a couple of systems that are in the present world that can be used, but we pick and choose 1 or 2 systems that works in our hands so that we can give the best service possible.
Okay, all right. My question is, I know with the single tooth, you have, you don't want to load it too heavy, and if you have just a single tooth, the dentist that did mine, it took it out of occlusion, which made sense to me. Kind of take it slightly out of occlusion. It's not the main weight-bearing tooth. However, if you have 2 quadrants or a lot of area, then they are load-bearing, right? So is it? What do you do differently if it is going to have a load versus just a single tooth, whereas the load is being carried by the other dentition? And that's kind of in my mind. When you have something that is going to be load bearing, what other precautions do you take, or do you wait longer for the healing and so forth?
Yeah. So whenever we do a single implants, we do check the torque. I mean, if the implant is spinning in the bone, then we will not put a healing abutment or a temporary crown on it. we'll just put the healing cap and then suture it up, let them come back after 3 to 4 months, so that the sigma cycle of the bone is like 3 to 4 months, so that the bone around the implant is formed, because we will fracture the bone and then put an implant in. So the initial bone will be an oven bone. This can be, I mean, if an orthopedician sees this video, he can easily catch it. So the capillaries will give you osteoclast, osteoblast, and then so these are the essential elements that will help us forming the bone around the implant. And implants are mostly made out of titanium, and due to which, so if you go see screws in the legs or in the hands or somewhere like that, they're made of titanium too. The same concept is being followed for the implants, but the implants are exposed to the outer world, whereas the screws that are in the bones are not exposed to the outer world. Due to which, when we expose it to the outer world, what happens is the microorganisms will go and sit in there again. We just need to maintain the implants like we do the other teeth as well.
So a lot of perio, or does it take more to maintain implants than the normal teeth?
Not really, doc.
Yeah.
Not really. It's like if you take care about implants like you do for the natural teeth, that's enough.
Okay. And
And regarding full mouth implants, so we do take into account the AP spreads. So it is called as an anterior posterior spread, and plan the implants in such a way that we can give the best fixed or a removable processes, so that the patient can eat happily and can come back and just get the service done, get the cleaning done, and then go back and be like the overarching goal is to give the best outcome with the best chewing capability.
yeah, and you told me that you wanted to do free exams for a period of time. We'll do free exams, and I'm following what he's suggesting. You know, he still has to make some money and profit still, but if he's suggesting it, we'll follow that because it makes sense. You know, to come in, most people don't really know a lot about implants, and then you want to be able to give them whatever treatment plan, and then not everybody can afford it. May need alternate treatment plans. But to be able to showcase what we can do and for them, or the alternatives that they can use is a big thing. And then they look at, and then we have a treatment coordinator that, and like I said, I don't normally do this with the kids. We don't normally have treatment coordinators. Some offices do. We happen not to. But I think it's essential when you have this, because there's so much explaining that you can do, and then there's videos and so forth to educate the patient, and then you need staff that are taught to educate them, go over the finances. As we were saying earlier, you don't really need to get into discussing the finances with people and the fees and so forth. So we want to put all of that structure around you. And then sometimes not everything is implant. And then you have the cosmetics and so forth, the denture or the partial or some other crowns that you may need to do, correct?
Sure, doc. So in adult dentistry, all cases cannot be treated as implants, and all cases cannot be treated as fixed crowns. Sometimes we don't have, the bone might be too much resorbed, and we cannot be able to build up the bone. In those instances, we might go with a removable. So the treatment plans that we give, it depends upon the patient and their present situation, clinical situation. We do offer free consultations right now because the patient should understand what are the pros and cons and whether we can deliver the service or not. So that's why we are doing free consults at this point, to get the perfect education for the patient so that they could make a good judgment out of it.
Yeah, and that's very, because a lot of times I see people that'll come, and fortunately, like I said, I've been doing just pediatric dentistry for a long time. However, I have a lot of friends and people from my Bible class and different things. They'll come to me and they'll ask me questions, and they'll say, well, Doc, I want to get all my teeth taken out and just get some dentures. And we were talking about that earlier. One of the things I always say, well, if you were having a problem with your leg, would you go to the doctor and say, take this leg off and just give me a prosthetic leg? is never going to be the same. And sometimes you have to explain to people, because I don't think a lot of people know that if they lose their teeth, it's going to be with, dentures and so forth, acrylic, the palate is covered, and plus they're flying out. Sometimes people that have dentures, they're talking and they have very little ridge and the denture will fly out and they're trying to hold it in. These are the things and reason, ridge preservation and so forth. So the teeth, and this is not for dentists here, but for you guys, the laymen that aren't dentists, the teeth set, they're in the alveolar ridge, and that's why you talk about ridge preservation and holding that, because if you get a denture, even if you get the teeth out, if you didn't have any ridge left and don't preserve the ridge, the denture is going to flop around and fly out. So that's a big thing as far as I see with, like I said, and it's outside of my zone of expertise. But I know that that's a big thing, especially perio and prosto and implant, is preserving ridge. You want to speak on that a little bit?
So whenever we take out the tooth has something called as a periodontal ligament in there, due to which it will hold the bone that will preserve the ridge. But when we take out the tooth, the periodontal ligament will be gone. And there are studies saying that the shrinkage could be 30-40%. Imagine a block with a hollow in the middle, and the block will shrink like 30-40%, and the vital structures are sitting right beneath it. And if you don't have some kind of, this bone will osteoconduct. That means it will induce, conduce, and will try to minimize the shrinkage by 60-70%. So
I told you he's smart, osteoconduct. And that was, see, you're kind of ahead of me. Go ahead, Doc. I like that. Go ahead.
So if you have a block, like imagine a bone like a block, and if you have a block that has enough bone around it, it's easy to place an implant. And while doing the fixed processes, if you want to do a bridge, if you have a block that is not resorbed, and if you get a bridge and the tooth will not be long, if it is too long, what happens is the foot will get impacted between the two pontics, we call it as a pontics, and that will be a harbor for the caries. So and when we do the dentures, if we have the bridge, then the denture will go and hold it. So that way, so there are many indications to preserve the ridge. And on top of it, when we extract the tooth, the tooth before it will get pockets. It's perio problem, because the bone that is behind it will resorb, and due to which there will be a pocket formation. That's why ridge preservation is very important, and it should be a standard of care, but I don't know why they are not doing it right now. But in the foreseen future, I can definitely say it will be the standard of care.
That the standard of care will be, if there's an extraction, you preserve the bone. Now, now what can you do if it's not an implant? Can you use anything else to preserve the bone aside from the full? Let's say a person isn't ready for the implant yet. However, you need to go ahead and do the extraction. What goes into the socket at that time to help preserve it?
Like we have different bones. We have, we call it as a demineralized bone, we call it as a mineralized bone. We just go put it, graft it, let it heal for 3 months. And then we can do whatever we want to with that.
So you can graft and put that bone in there, preserve the ridge, and whenever you're ready to come back, you can put an implant.
Put an implant, put a bridge over there, put a partial over there, so that the partial won't rock.
Yeah, it's still, you preserve the ridge by. So and I'm a dentist, and I wasn't aware, because I was thinking that it was the tooth itself, but you said it's the periodontal ligament. Mm-hmm. So, but if you take the tooth out, and you put the demineralized bone in there, it still preserves the periodontal ligament?
No, periodontal ligament will be gone. It preserves the shrinkage of the bone.
It preserves the shrinkage. So it kind of replaces the periodontal ligament where it was. Or it stimulates the same kind of bone that the periodontal ligament would do. Sure.
So when we put something in there, it has something called as bone morphogenic proteins. Bone morphogenic protein type 8 will be in demineralized bone, but we sometimes need a scaffold. I mean, we cannot build a house without a scaffold, right? So likewise, we sometimes might use a membrane, we might use a bone, and that is completely good, and it will osteoinduct, that will osteoconduct, and sometimes we use something called as rapid accelerated phenomenon that will go and we will put some notches so that we'll get some bleeding, and the bleeding might act as a scaffold. So there are a couple of ways to do this. The only thing is, when you come to us, you will get to know the different treatment options that we could deliver to you, and I can definitely say this: without extracting the tooth, I cannot say what kind of a graft I'm gonna do there. So, but we could to an extent say after looking at the CBCT, but only after extracting the tooth and see how the bone is behaving, because imagine like a jacuzzi. Okay, you have 4 walls. We need blood from all the 4 walls to make sure that the graft is soaking in, and the graft need to be assimilated into our body structure. That way we'll get a solid bone there, which could help us to place an implant, build a bridge, do a partial. And let me tell you about something about partials. If you lose all the back teeth, you have only front teeth. I'm not gonna extract the front teeth and do complete denture on that. So what I'm gonna do is I'll build a partial. I will use these teeth as a markers and put an implant at back of it. In the foreseen features, if you lose the front teeth, you can still use the back implant, and you can just put 2 more implants and build the denture out of it. So I'm not like, I don't want to destruct the entire house. I will play with whatever I have in the hand to make sure that I give the best delivery for you.
In that case that you were just talking about, though, with so we have the anterior section, but we have no posterior teeth bilaterally. You're going to put something back in the ramus back here so that it's fixed in place. Is that how you're saying?
So the implants will be slightly in the anterior region. So it likes like a cantilever, if you remember.
Okay.
So the cantilever action will be reduced when we put an implant.
Right. Okay.
So that way we will put an implant right there and make sure they lost it. They would have lost it to caries. They would have lost it to perio problems. They would have lost it because of both the problems.
The molars and the bicuspids. But okay, because I'm trying to envision, we may have to do a graph, put a little graphic up on this to show everyone what you're talking about. But I'm trying to envision this. We still have the lower anteriors, and you're saying we're not going to put anything on it. Where we're going to put the implant, though?
At the back of the lower anteriors,
At the back
just at the back of the lower anteriors, and then so we can just let the denture sit on it, the partial denture sit on it, and if they lose the front teeth in the future, we can just add 2 more implants and convert the partial into a complete denture. So you need not extract all the teeth. Natural teeth are the best teeth.
Use those and that's the thing I want to encourage anybody out there that's thinking about whether it's a denture, replacing implants or whatever, anytime. And I'm telling you, and this is not trying to sell you anything. This is just going based on what I know. It's always best to have what God gave you and not lose anything else. You want to stop. And that's why his background in perio, because periodontics has to do with the gum and the surrounding structures that hold the teeth in place. You need a background like that And we're from a little small town in North Carolina, and they had a community get together, and then we were talking about how many people have bad teeth, and some of them have money in their pockets, but it's the mentality that we've grown up with sometimes, whereas we don't understand and don't know that leaving those other bad teeth, now you're setting yourself up to lose all of them. And if you lose all of them, then you're winding up with the dentures, and they are not going to be the same as your natural kind of teeth and your mouth when you have acrylic and all of that that's covering your palate and so forth. The one thing about, at least with implants, if you leave a little bit, they don't have to cover your entire palate to put something in there to get it fixed, correct?
Yes, doc. Yeah. So back in the day when you were practicing, you remember you used to take agar-agar impressions, alternate impressions, and the patient will be gagging. They'll not be happy with the plastic or anything that goes in the mouth,
exactly.
But still they have to do it.
Yeah.
Because there's no alternate choice.
Oh, yeah.
Right now we have some alternates going on, like with the implants.
Oh, yeah.
All right, so that they can actually treat it like natural teeth.
Yeah.
And chew it like natural teeth. I mean, implants are not close to natural teeth, but they are 80% close to natural.
Yeah, much closer than some of the acrylic stuff and so forth. And I like what you were saying about the impressions, and now being able to get a digital impression. I remember when I was in New Orleans, we were practicing, and we wanted to do something for this lady. It was a denture, but needed to get that impression. And she had been in two times, and she just could not stand anything that hit her palate. And I remember Dr. Roots, my other partner associate working there, he said, I'm getting that impression today. And he held it in, she was throwing up, it was going off, throw up was going all in his pocket and down his sleeve. But he was like, just hold your head forward, breathe through your nose. And it was just, and I don't know how she could wear a denture later after that, but it was bad. So the thing we're encouraging you guys to do is just, whether you're a dentist, don't let your patient go that far. Or if you are someone just listening that are thinking about, what's the next stage, don't let it go until you're at the end of the bridge or going towards a wall. And because when you lose your teeth, it's not equivalent. You only have two eyes, but you can imagine losing half the sight in one eye. You're not going to see as well. And if you lose one eye, then you're really not going to see well. So just think about your teeth. And this is something that we experience all the time as dentists. People just don't respect their teeth, like everything else in the body. Or if they do, a lot of times it's just their front teeth, and don't care about the ones in the back. Right. Yeah, and sometimes a lot of it is due to education and environment that we come from and so forth, culture. But we're trying to raise that education and awareness in the community. And hopefully the government, so forth, will start supporting more of these things. Because right now, and I know a lot of people always say, well, dentistry is so expensive, but dental education is also expensive. Everything that you buy that's going to take care of the dental procedures, and the dental insurances now are paying that $1,000 or $1,500, same as they were back in 1960. Mm-hmm. Dentistry has become something you go to a dental office, you expect to spend $3,000-$4,000 on if you haven't had work done in a few years and you haven't been getting your cleanings. And then if you're getting implants, you're spending a lot more. So hopefully employers and the government will start spending more on these kinds of things, because it is expensive.
Dentistry is expensive. There's no doubt in that.
Yeah.
We bought an iTero scanner, which is like $35,000. Come on.
Just to get a scanner, and then when you talk about CBCT and the new one, running about $100,000.
Right.
Yeah.
Right. And one more thing is, I want to add one line for this. Come visit us every 6 months. You will see a change.
Yes, every 6 months. And that's the best kind of insurance you could have, rather than saying, well, what's the good insurance? Every 6 months, see your dentist. Go and get and get in the chair, get a good hygienist or someone clean your teeth, make sure they're looking and doing preventive kind of things and catching things early. Don't wait until it's too late. It's almost like getting the oil change on your car. If you do it on a regular basis, you preserve the engine. If you wait until you hear those pistons knocking, you're probably in trouble. You know, you waited too long, and now you got to go all the way to the end and get some aggressive stuff done.
And for the kids also, whatever I'm watching is they are losing permanent molars at the age of 13, 14, something like that. And how can the kid survive the next 80, 90 years without having a molar and to eat something?
Yes.
So you need to really take care about the teeth and get it examined every 6 months. Every body is different. Every tooth is different. Everything is different. The anatomy is different. So come back to us. We know how to prevent it. Implants are the last resort, but they are a good resort. Okay?
Yeah. And a dental home is something that we've been talking about for the past few years. I think that if you have, because someone, I even told people this, and they said, well, I used to go to this dentist, and they were the best dentist in the world, blah, blah, blah. And I'm thinking, I probably can't live up to the best dentist in the world, and you probably need to go back to he or she. But you want to have a dental home, and that's when they come to me. I want them to feel like I'm your dentist. I'm your dentist. Even if you're somewhere else and you get some emergency treatment, you're coming back to me because I want to make sure that we keep all of your records in place. We know what's going on. We see you, like you said, every 6 months or even more if you need to. You know, it's no law so you can't come in a shorter amount of time. You know, it could be 3 months if you're having problems with cleaning and hygiene and so forth. But make sure you see someone every 6 months.
Sure, Doc.
Every 6 months.
That's for sure. And thanks for your services that you did to the kids all these years.
Oh, man.
And establishing something, the concept called as a dental home.
Yes.
And which is very important because everything starts from when you start drinking from a cup. Okay.
Can I do a shameless plug? This is my book. This the Entrepreneur Dentist: How to Exit Your Business Rich. I was able to sell. I've had almost 30 practices over the years. I sold 14 when I exited. I had sold some dental offices to some of my associates previously, but I was able to exit in 2017, and it was unbelievable. I did exit rich, and I'd like to be able to pass some of those things along. So I have this channel, this YouTube channel, The Entrepreneur Dentist, and also, like I said, the book. It's available on Amazon. And if you want to be an entrepreneur dentist, and this doctor he's doing the clinical stuff right now, but we're also talking about entrepreneurship and some of the things that, because, you know, I'm an old guy, I'm not going to be around forever. I like to pass some of these things along. So what I'm doing is trying to mentor young doctors on how to be able to exit one day and exit very wealthy. Because dentistry, I see as a profession that you put a lot into, and you have to be able to leverage it to the point that one day and the way to do it, I have a poster out in the hallway from Zig Ziglar. He said you could have anything that you want if you could help enough other people have what they want. So along the way, you become a teacher and mentor other people and bring them in and show them how to do some things. And then you go on and help more and more, and you build more and more practices and partnerships. And because at some point you have to be able to take vacations, take time off, go places, and you don't want your money to stop every time you stop. So, and that's another thing in my book I talk about. If your money stops every time you stop, you probably need a better plan. And you don't want to start out necessarily there. You got to learn everything about the whole clinical thing, and then you want to start learning the business side, and then you eventually want to build a model whereas you can replicate it here and here and here and pull other people along behind you and get them doing what you know how to do, and you can just monitor them. So it's a beautiful ride. If you buy the book, you can also start to watch my YouTube videos on entrepreneur dentistry. And if you'll send me an email, entrepreneurdentist@gmail.com, then I'll tie you in to some of our webinars and some of the trainings that we're doing. But I just enjoy you guys being here and meeting Dr. Anoop Nandanoor, and let's just refer patients to him if you're in the area, or if you're a patient that's looking to have some implants, some cosmetics. I have one of the best. I've invested a lot in this man not because I just wanted to invest. I would not invest in him unless I knew that you were the guy to do it. And thanks for coming
Thank
on
you so
board
much,
with
Doc.
me, Doc.
And one line, last line, he's a great mentor. Okay, he treats you like a kid, and he will try to bring you up. So I'm very happy to work with him.
Thank you so much, Doc. And I'm proud to get something like that from a man like this. But that is what I'm trying to do right now. I'm trying to mentor, but I'm also building out. My dream, I'm having fun. I want to later show you some of these offices that I recently built out. I bought properties, I developed them, built them out, and it's like a little dreamland. Some of the things that you get to do, and I'll tell you more about that. But thank you for joining us today. Thank you.